Hello, my name is Victoria McCredie. I'm from the University of Toronto. I'd like to thank the organisers for inviting me to talk today about setting PEEP in ARDS and why it's complicated in head trauma. Overall, I have no conflicts of interest or disclosures relevant to this presentation. First of all, I want to talk about ARDS in traumatic brain injury. Really, brain injury patients have been excluded from randomized controlled trials of ARDS, but the pre-Berlin criteria era, we saw that ARDS within severe traumatic brain injury occurred anywhere from about 20 to 30%, with a subsequent mortality of about 28 to 38%, depending on which study. But there was a number of concerns, and most of that data was taken from sub-studies and retrospective small single-center studies. So on my recent review of the literature, I could find two of these that have been published since the Berlin definition came out. And the first one is by ISICEM and colleagues, which is actually looking at the data from the EPO trial from Claudia Robertson's, published in JAMA, looking at EPO and transfusion in brain injured patients. And the second one is by Hendrickson and colleagues, published also in J-Trauma in 2016. And this again was data taken from a larger trauma population, looking at transfusions and hemostatic resuscitation. And in the or the era of Berlin definition, we can see that ARDS overall seems to be similarly when they use that Berlin definition. There was strengths of these studies where they had adjudication by at least two physicians, blinded to outcome and blinded to intervention, and then also looking to see classing them as mild, moderate, and severe ARDS. And we can see overall in these populations that within severe traumatic brain injury, and I must say that both of these groups included mostly isolated severe traumatic brain injury, that we can see that the majority tend to have moderate ARDS. And looking at their adjusted model, so both of them papers looked at unadjusted and adjusted associations. And overall, we could see within the ISICEM paper that there was associated with increased severity of illness, and also pre-hospital hypoxemia seemed to increase their odds of, their hazard ratio model, looking at increasing hazard of developing ARDS, as opposed to within the Hendrickson study, where they found that there was almost a 2.5 increase in odds with platelet transfusion early on in resuscitation within the first 12 hours, as well as being male, seemed to be associated with your development of ARDS. Overall, there was a significant difference in mortality between the ARDS patients in severe traumatic brain injury versus the non-ARDS patients. If we think about some of the concerns also within these patients is possibly how we ventilate them. And historically, we thought of a brain-directed strategy, which may leave us open to actually causing more lung injury or lung insults versus a lung protective ventilation. We look at how these may be different. Well, both of them try to optimize oxygen delivery. While as in our brain-directed strategy, we tend to think about tighter control of carbon dioxide, and that usually is through higher potentially tidal volumes and minute ventilation. While as in lung protective ventilation, we think about trying to avoid over-distension, so volu trauma. There was also in brain-directed strategy being the thought to try and minimize the potential effects of PEEP, and while as in lung protective ventilation, we've always thought about avoiding cyclical collapse, i.e. atelic trauma. And overall in brain-directed strategies, there's been the overall need to try and avoid increases in intracranial pressure and to stop any inadequate perfusion or flow to the brain. So thinking about ARDS and lung protective ventilation, I actually pulled out some more data from that ISICEM study where they looked at severe traumatic brain injury, excluding life-threatening systemic injury, so mainly isolated TBI. And here they actually gave us some data about how they ventilated them. And before the development of ARDS, out of the 200 patients, there was 128 that they had this data on. And the median ventilation, tidal volume, was 9 milligrams per kilogram. So a little higher than what we usually use for lung protective ventilation strategies. But looking at the differences in tidal volume between ARDS and non-ARDS patients, there was no statistical difference. And once ARDS was identified in the severe TBI group, they used what was called lung protective strategies, although there was no further elaboration of what that is. Unfortunately, there was no data on PEEP, so that can't help to inform us there. So we're going to try and think about PEEP effects on cerebral physiology more from a physiological perspective in theory. And the potential benefits of PEEP in this population are to improve systemic oxygenation. We also think about improving overall cerebral oxygenation and limiting the utilization of high FiO2 and preventing cyclical lung recruitment or de-recruitment cycles. There's been some nice animal studies to show that this is actually cyclically transmitted to the brain with this lung recruitment, de-recruitment, and drops in the PO2 transmitted to brain oxygen. There's always concerns about PEEP, and here is how I want to conceptually think about it. So increasing our PEEP may cause a higher intrathoracic pressure, raising our central venous pressure, and through that Starling resistor effect between the collapsing veins and the sagittal sinus, which is non-collapsible, as our CVP rises greater than ICP, there's always the concern that you're going to decrease cerebral venous outflow, causing an increase in cerebral blood volume and an increase in ICP. There's also the concern of inappropriate alveolar hyperventilation, causing an increase in your CO2 retention, cerebral vasodilatation, which is increasing your arterial inflow and overall increasing intracranial pressure. There is also within the intrathoracic pressure concerns that on the systemic side, by decreasing your venous return and decreasing your preload on the systemic side, overall dropping your cardiac output and dropping your MAP. And if cerebral autoregulation is intact, this also may cause increase in your cerebral blood volume due to an increase in your arterial inflow as you appropriately cerebral vasodilate. This is where it becomes complicated because we're talking about differential effects here that it may cause high intrathoracic pressure, it may cause hyperinflation. It depends, it seems, on what your autoregulation is doing within your brain and overall what your intracranial elastance or compliance is doing and whether you can tolerate all this. There's a lot to unpack here, but I'm going to talk about two concepts. One would be the lung compliance issue. And here's a study by Caracato and colleagues in J Trauma, where they looked at lung compliance within, I think it was pigs, looking at the hemodynamic effects of PEEP. And when patients had the pigs had a normal lung compliance, they found that overall, as they did a PEEP study, a stepwise increase in PEEP, they had an overall drop in MAP and a decrease in cerebral perfusion pressure. Oops, sorry, there's a bit of a problem there with how that's displayed. But as they looked at patients or participants with a low compliance system within their respiratory system, as they increased the PEEP, they found no change in the MAP or cerebral perfusion pressure. So it seems that as your lung compliance changes, i.e. it gets worse within an ARDS picture, it doesn't seem that PEEP titration is transmitted up to the brain. If we look at the concept of cerebral autoregulation, you'll have seen this many times that intact cerebral autoregulation, but we know that most of our patients in neurocritical care have a right-shifted lower limit of autoregulation and have impaired pressure dysautoregulation. Here is a study by Munch and colleagues where they looked first in animals in a pig model where they did a stepwise increase in PEEP, and they looked at in pigs who had intact cerebral autoregulation, and they could see that there was no change in intracranial pressure or brain tissue oxygenation and no change in cerebral blood flow. If we look at, in the same paper, they then looked at PEEP in humans in a stepwise manner, increasing PEEP2. These patients had a loss of autoregulation, and they could find that as they went up on the PEEP, they found that overall there was no change in intracranial pressure, but a drop in MAP and a drop in cerebral blood flow. And they also had some brain tissue oxygenation monitoring, and they could find that overall that dropped through that PEEP recruitment maneuver. So if we add that into our theoretical concept or conceptual diagram, when you have intact cerebral autoregulation, there seems to be an appropriate cerebral vasodilatation, but that may cause an increase in your cerebral blood volume and an increase in your ICP. Whereas if you have cerebral dysautoregulation, it seems to cause a decrease in your cerebral blood volume and potentially a decrease in your ICP, but also remember potentially a concern about cerebral ischemia. There was a really nice paper recently by Chen and colleagues, including Brian Kavanagh and David Menon, where they looked at altered airway pressures as a review of the literature, and they found that overall there was an increase in ICP as the increased airway pressures. But what is significant is that change at delta in ICP was significant, but most of these values were still less than 20 as they increased PEEP. Overall, summarizing the literature, they found that altering airway pressure on the brain seems to depend on 4 factors: your lung chest wall compliance, lung recruitability, cerebral autoregulation, your baseline intracranial pressure, and your cerebral compliance or elastance. And your ICP, the effects may be differential on your airway pressure. ICP may be unchanged, increased, or decreased. And so if we add all of these concepts back in here, we can see that within those 4 areas, and we've touched on 2, which was lung compliance and cerebral autoregulation, there is a number of ways where, as you're trying to understand and titrate PEEP, that may have an effect on our overall cerebral blood volume and ICP. I just wanted to quickly bring in this very recent publication by the ISICEM group, the Ventilo survey, where they looked at over, I think about 687 participants over a number of centers, mainly intensive care physicians and anesthetists answered this survey and had over 10 years experience. And they mainly worked in mixed or general ICUs and mainly in academic centers. But we want to see how, looking at that theoretical concepts, and at least there's not great evidence right now of what is the most appropriate PEEP, how people are doing it. And the survey looked at 3 scenarios, and we could see that the scenarios were mild, moderate, and severe ARDS. When there's no intracranial hypertension concerns, it seemed that the people were happiest with a PEEP of 15, and the choices were 5, 8, 10, 15, or an other value. But most chose 15 as their highest PEEP. Whereas when we move into actually patients that have severe traumatic brain injury and intracranial hypertension, we can see that as their PF ratios get better, their tolerability for higher PEEPs diminishes. And even at a PF ratio less than 150, we could see that overall the majority favored a PEEP 10 and below. This is a really nice paper from McCredie and colleagues. And I'm not going to go through it too much, but it's actually a way at the bedside to incorporate brain ultrasound and lung ultrasound in a stepwise manner to look at recruitment through PEEP recruitment, to try and titrate your PEEP to your intracranial pressure values, to try and look at a pressure that is appropriate one for your brain with minimal impacts on your intracranial pressure through measurements of optic nerve sheath diameters, as well as pulsatility index and diastolic flow velocities, as well as trying to find a PEEP that is favorable for lung recruitment. And so I would say that this is well worth a read. So my take-home points for PEEP and trying to set it in ARDS patients in brain injury, knowing that it's complicated, is that it appears that moderate levels of PEEP are safe, but it's very important to titrate PEEP against individual responses. And how I use PEEP is to ensure there's adequate filling pressures to avoid potential drops in MAP as I increase my PEEP. Also think about keeping the head of the bed elevated to diminish interthoracic pressure effects on the brain. In my patients that have neuromonitoring, consider following ICP closely. And then also think about monitoring carbon dioxide by always putting an end tidal monitor on these patients and correlating it or looking at the agreement with our arterial PCO2 measurements. So I'd like to say thank you for letting me talk to you today about setting PEEP in ARDS and brain injury. And now I will open up to questions.